I am Dr. Surender. I will be discussing today about spinal anesthesia. The first spinal was given in 1885 by Corning. He was injecting the local anesthetic drug into the rectal region, accidentally needle pierced and went into the subarachnoid space. First therapeutic spinal was given by August Bayer on 16th of August 1898. Atkins popularized the spinal technique and he noted the importance of spinal curvatures. Spinal was very popular till the Roe and Woolley case. Roe and Woolley both were anesthetists working in Great Britain, and they gave same afternoon spinal anesthesia to two different patients. The outcome was the same. Both the patients developed paraplegia, and there were arguments, counter-arguments. Meanwhile, the evidence has come back. In those days, local anesthetics they used to store in alcohol. So the phenol might have seepaged into the, but through the cracks of the ampoules, and as you know that phenol is a neurotoxin. Then spinal has become less popular after this case, but more and more number of epidurals replaced spinal anesthesia. India being a developing country, we use spinal anesthesia very commonly, since it is a simple procedure. There are about 31 spinal vertebrae and 33 spinal nerves. Each vertebra consists of a vertebral body and posteriorly projection spine and a plate of bone known as a lamina connected with the pedicles. Anterior to the spinal cord is the anterior longitudinal ligament. Posteriorly, we are not concerned with that one. And posteriorly, there is a posterior longitudinal ligament. Then skin, subcutaneous tissue connecting the tips of the vertebra, spinous processes is the supraspinous ligament. Connecting the spines in between is the interspinous ligament, and the thick, dense, fibrous ligament known as a ligament of flavum and the dura. So these are the structures. Spinal cord ends at the level of these are the structures: vertebral body, ligament of flavum, supraspinous ligament, interspinous ligament. Then the spinal cord ends at the level of lower border of L1 or upper border of L2. Usually we attempt spinal at L3-4 and or L4-5 interspace. We will not go above L2 because there is a danger of injury to the spinal cord. Spinal cord being a central nervous system doesn't have a neurolemmal sheath, so regeneration of spine, injured cord cannot occur. Whereas the peripheral nerves have got a neurolemmal sheath and regeneration can occur very easily. That's why we will not perform spinal anesthesia. Then the CSF is there in the subarachnoid space between the pia mater and the arachnoid mater. when we go, our spinal needle will enter into the supraskin subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and enters into the subarachnoid space. This subarachnoid space, because of the blood-brain barrier, antibodies and antibiotics will not reach in sufficient quantities. So when spinal anesthesia should be done under strict aseptic precautions. The procedure of the spinal anesthesia. Preoperatively, patient must be examined by history, clinical examination, investigations, and during the procedure he should be explained about the procedure, and you should take in confidence that patient will be in a conscious state, and but he will not feel the pain. Pre-medication not always necessary. If it is an anxious patient, one can give anxiolytic. Position, it can be given in lateral position or in sitting position. In lateral position, the patient is placed on the edge of the table, the shoulders and the hips. There should not be any rotation, and knees flexed onto the abdomen, so as to make the intestinous web space more wide and open. And sitting position, patient sits on the edge of the table with legs supported by the stool, and gently flex the head of the patient. You can feel the intercostal line at the highest point of the iliac crest, and this is processed through the L4. And females, especially when they lie down, the spine curvature is like this. So you must always keep a pillow underneath the head so that the drug will not ascend up capillary. This is the intercostal line passing through L4. If the patient is obese, unable to sit, unable to lie down, flex legs, or patient in the orthopedic case where there is a fracture in the lower lip, should in that case, sitting position is the ideal position for spinal anesthesia. Spinal can be given by midline approach or paramedian, 1 centimeter lateral to the midline, and you go in a medial direction. The inclination should be slightly more capillary. Tailors or lumbosacral block is very useful in patients' ligaments are calcified. Here we feel for the posterior superior spine, 1 centimeter lateral, medial to the spine. We make entry into the skin and negotiate the medial and goes into the spinal needles are various types, cutting needles and non-cutting needles. These cutting needles will cause dural puncture hole, and as a result of that one, there is a possibility of post-spinal headache is slightly more. Whitaker and Spinal these are the non-cutting needles, but there is a possibility of the eye of the needle is not at the end of the it is in the middle. So that I thought there is a possibility of partly depositing in the subarachnoid space, partly outside is a possibility. This is a cutting needle. The dural hole is a little big, whereas this non-cutting needle, the dural hole is very, very small. And because the Whittaker needle and non-cutting needles, they make pencil point needles, make smaller hole, the incidence of lower incidence of post-spinal headache. Local anesthetic used is usually we use hyperbaric, but there is isobaric solutions are also available. Nowadays we are not using hyperbaric solutions. Bupropion 0.5%, isobaric bupropion nowadays not very popular. Ropivacaine and levobupropion are commonly used, but bupropion 5% is nowadays we abandoned because of the TMS. Various adjuvants are added to the spinal anesthesia. Adrenaline, formidin, dextromethorphan, neosporin, and phenylephrine. Then these will prolong the motor and sensory blockade and duration of postoperative analgesia. And spinal blocks the visceral fibers, somatic fibers, whereas visceral fibers are blocked by these adjuvants such as fentanyl. So patient comfort increases. Should know about the segmental level to which, suppose we want to give a cesarean section, T4 level, umbilicus should go. Zipisternum is at T6, umbilicus is T10, groinal ligament is L1, depending on the mid-spinal or high spinal, one can plan depending on the surgical procedure. Factors affecting level of spinal anesthesia is the varicity of local anesthetic, dosage, concentration and volume injected, site of injection. Higher the injection, more likely to spread, more likely. Position of the patient at the time of injection and soon after the injection. And if the patient is too tall or too short, there is a possibility your dosage, usual dosage may be under dosage or over dosage is likely to occur. And you should check for the spinal curvature, spinal curvature, which is some abnormal, there is a possibility of either high blockade or low blockade. Pregnancy because of the curvature, exaggeration, as well as epidural plexus of veins engorged with blood vessels, the higher blockade because progesterone decreases the dose of the local anesthetic, one-third reduction must be applied. Physiology of spinal anesthesia, nervous system. It affects all motor, sensory and autonomic fibers. For the autonomic fibers and the posterior column sensations are must be blocked. Other autonomic fibers are must be blocked. Posterior column sensations usually will remain and must be blocked. Order of blockade are sympathetic, followed by temperature, followed by sharp printing, followed by there is a differential blockade will occur in patients with spinal anesthesia depending on the concentration used. Recovery will occur in the reversal. is the order of the blockade. The cardiovascular system, usually there will be hypotension is because of the sympathetic blockade, pooling of the blood in the lower limbs, lower part of the body, decreased venous return, decreased filling of the heart, and decreased cardiac stroke volume and the cardiac output and therefore this second reason why this one is the vasodilatation which occurs that decreases the venous return. Third is the reason is loss of peripheral pumping mechanisms of skeletal muscles. Then coming to the heart rate, there can be tachycardia because of the varus reflex. Some patients will exhibit bradycardia because of the Bainbridge reflex. Depending on the preponderance of one reflex or the other, either patient will have a tachycardia or bradycardia or tachycardia. Respiratory system, it has little effect on the pulmonary function, and patients with CVM mainly rely on intercostals and abdominal for respiration. We should remember that the relaxation of these muscles thus decrease the expiration and associated with decreased clearance of tracheobronchial secretions. The blockade of sensory input to the patient may complain of difficulty in breathing. Mechanism is described as inappropriate response to given muscular effort. Patient believes that she is not exerting effort sufficient to maintain the breathing. This can be managed by a patient to take a deep breath and provide supplementary oxygen and reassurance. Gastrointestinal system usually symptomatic blockade leads to unopposed parasympathetic activity. As a result of that one, there is an increased contractility of the gut and sphincters are relaxed. The biliary reflux may occur into the stomach or esophageal reflux can occur that can cause some amount of discomfort in the rectostomal area. Liver blood flow and renal blood flow will decrease. Endocrine functions not much altered. Stress response is limited. Endoscopy anesthesia. Thermoregulation because of vasodilatation. There is a decrease of temperature around 1 to 2 degrees. Indications for spinal anesthesia is this should be reserved for below umbilical surgeries, which are done in all operations of the leg, orthopedic cases, gynecological, general surgical patients, usually neurological patients, and super patients. Coming to the cardiac complications of spinal anesthesia, most important immediate effect is the hypotension. The hypotension is caused by the pooling of the blood in the lower limb, decreased venous return, and also skeletal muscle. Peripheral pumping action of the skeletal muscle is lost because of the paralysis. And sympathetic supply to the adrenal gland is also blocked. So these are all the causes for spinal anesthesia. Rarely total spinal can occur and you are not taking care about the position of the patient, proper positioning of the patient. Especially this can occur in pregnant patients. Urinary retention is a common problem. Sympathetics of bladder will regain very slowly as a result of that one. urinary retention is common. Epidural hematoma and bleeding in the epidural space can occur in patients who are on anticoagulants or patients who are at a liver disease, prolonged bleeding tests. Late complications in the post-pleural function. If spinal hypotension is severe enough, interfering with the vital organ perfusion, you must give a vasopressor. Despite depending on the type of spinal hypotension. If the hypotension is associated with the bradycardia, you can easily correct it by giving the atropine intravenously. 0.4 to 0.6 milligrams. If hypotension is associated with tachycardia, phenylephrine is the drug of choice. If hypotension is associated with normocardia, ephedrine or methadone should be given. Late complications is the post-dural puncture headache. Dural puncture headache is more commonly because of the low pressure headache. That usually occurs starts after 24 hours, but usually more common in the first 3 days. And it has got a peculiar characteristics. Usually it is frontal or occipital patient is more common, aggravated by sitting position and relieved by lying down and abdominal compression. So, this low pressure headache usually treated with bed rest, fluids, intravenous or oral, and simple analgesics, especially analgesics with caffeine, will be more helpful in these patients. If spinal headache continues, sphenoid block useful in these patients. Spinopalatal ganglia block. If spinal headache not relieved with routine methods and troublesome the patient, then we may have to give autologous spectrum blood patch in patients with spinal headache. Rarely spinal headache is because of the meningitis, high pressure headache type that is treated like any other meningitis with antibiotics. Backache is very rare unless you have caused damage to the disc and disc prolapse. Usually it subsides with simple analgesics. Focal neurological deficits, very rare. Adhesive acantholytitis is possibility when you have given preservative drugs with preservative into the subretinal space. This is a possibility. Interspinal artery syndrome can occur in an elderly patient where there is a severe hypotension and not corrected in time. Active meningitis is very rare with the present day anesthetic techniques using aseptic precautions. Although we used to do the preloading of the 1-to-1 blood corticosteroids in the preoperative period before giving spinal anesthesia, no, we rarely do this. We usually do the co-loading of the patient. And spinal anesthesia is hypotension occurs with the elevation of the legs. One can do only after the fixation, local anesthetic into the nervous tissue. This fixation will take about 15-20 minutes. So after the 20 minutes final anesthesia, you can elevate the legs. But before that, you should not elevate. If you elevate, there is a possibility of your spinal blockade ascending up. Intravenous fluids, vasopressors, and oxygen inhalation. Bradycardia rarely troublesome. Then usage is ideal. Rarely, because of the high spinal, respiratory paralysis and respiratory varices can occur. Usually, patient is high enough, so we have to intubate the patient and control the ventilation, and also treat the associated hypertension. Nausea, vomiting, although it is rare, any patient who is vomiting under spinal anesthesia, you must suspect hypertension. And rule out hypertension and treat aggressively hypertension. Otherwise, reassuring the patient, oxygen supplementation, antiemetics. Total spinal high spinal can occur when there is curvature abnormalities in pregnant patients, when you are doing a little larger dose and you are not taking care about the spine stable position before giving the spinal anesthesia. The management depends on the level of blood pressure. If it is level is quite enough to cause the respiratory paralysis, then it is better. Protective cough mechanisms and others are gone, then better to motivate the patient. Present day methods, broken needles is very rare. The spinal anesthesia blood tap is likely to occur when as you are puncturing the ligament of flavor must enter and stop. If you go and further and touch the posterior spinal longitudinal ligament, then there is a possibility of epidural plexus of veins likely to be punctured there. The epidural hemorrhagic tap is more likely to come in the paramedian approach rather than midline approach. Urinary retention is the most common complication because of the blockade of the S2, 3, 4 nerves, and these are very small nerves and require very few. All those spinal factors come in spinal effect. This neural blockade may persist. If it is troublesome, we have to do catheterization. Spinal anesthesia, we have already post-spinal headache, we have already discussed this. Meningitis can be aseptic or infective meningitis. Infective meningitis treated with antibiotics. Aseptic because of the blood spots and betadine, Antiacidone is very rare, usually seen in continuous spinal with large bore catheters, fine bore catheters, and this is characterized by retention of urine, incontinence, loss of sexual function, loss of sensation in the perineum. This, because of that, microcatheters abundant with the help of present day spinal catheters, it is very rare. Chronic adhesive erythroiditis can occur in patient whenever you are dealing with some preservative drugs with preservative into the subarachnoid space. Epidural hematoma can occur very rarely because the patients who are on anticoagulants and the hemocoagulation profile is abnormal without correcting somebody whose administration is very common. Epidural abscess is a dreaded complication. This is likely to occur. This may cause compression of the cord, then requires immediate neurosurgical intervention and decompression must be attended. Cardiac arrest can occur if there is a severe hypertension, total spinal or local anesthetic toxicity. Anaphylactic reaction, immediate CPR must be expected. Advantages of spinal anesthesia is low cost, patient satisfaction, respiratory diseases, it is the drug of choice, it does not interfere with the instrumentation of the respiratory tract, patent airway, there is no airway securing, failure to secure the airway doesn't occur. Diabetic patient, there is a little alteration in the metabolic status, good relaxation, blood loss is less. Disadvantages is contraindication, inadequate resistant to drugs and equipment. There is a coagulation fatigue, there is a severe hypovolemia, patient refusal, raised ventricular pressure, and cardiac lesions with restricted relative contraindications, uncooperative patients, pre-existing neurological disease which is progressive, stenotic valvular diseases, severe spinal deformities, lack of consent. Patient should be allowed to leave the recovery room only after the blockade is receded. At least 4 dermatodes regression of the spinal should occur and should be hemodynamically stable. Outpatient should be able to ambulate without any orthostatic hypotension, able to void the urine, then they can be discharged. Thank you. Madam,